So good afternoon, everyone, and welcome to the ID-EPI seminar series presented to you by the Center for Communicable Disease Dynamics and the Harvard T.H. Chan School of Public Health. And today is also co-hosted by the Blavatnik Institute at Harvard Medical School. This is the 8th seminar of the series. I'm Flavia Camponovo, and I will be moderating this session. We are excited to welcome with us today Mohamed Samakula. He is a senior statistician and health scientific innovation analyst in the Rwanda Biomedical Center's Research Innovation and Data Science Division. And he's leading the COVID-19 data science and IT solution response for Rwanda COVID-19 Joint Task Force. So before we get started, let's just cover a few logistics. So the seminar is being recorded, so please turn off your camera if you do not wish to be on the recording. And this recording will be available on our website at a later point in time. Mohamed Samakula will have approximately 40 minutes for his presentation, and then we will stop for questions. Throughout the talk, you can send questions via the chat function to Bene, and you're welcome to ask your question yourself. If you wish to do so, please specify this in your message to Benedict, and we will call your name during Q&A. So we're thrilled to have Mohamed Samakula with us today as he describes how Rwanda managed to control COVID-19. Mr. Samakula is currently doing a joint PhD in data science and biostatistics at the Hasselt University in Belgium and University of Rwanda's African Center of Excellence. He is a member and chair of the steering committee in charge of establishing Council of Rwandan Statisticians under National Institute of Statistics of Rwanda. He is an active member of Civil Registration and Vital Statistics Expert Group in Africa, and a graduate statistician member of Royal Society, Statistical Society in United Kingdoms. Mr. Samakula has worked on many different projects. To name only two, he contributed to the strategy of harmonization of statistics in Africa and coordinated the elaboration of Rwanda HIV National Strategic and Operational Plan 2017-2023. He has a strong knowledge in data modeling and management of big data sets, such as national surveys, and mainly works on observational health data, focusing on statistical methodology and estimating inference, monitoring and evaluation, and demography and spatiotemporal modeling. So thank you for joining us, Mr. Samakula. And without further ado, let's get started.
Thank you very much for the introduction, and thank you for this opportunity to just share our experience on how Rwanda is trying to manage COVID. Maybe before starting, it's better I give a background of Rwanda for those who are not aware of Rwanda. Rwanda is a small country in East Africa with 12.5 million people, 5 provinces, 30 districts, and 416 sectors. But when you look in terms of the health facilities on the other map, you will see that we have about 8 reference hospitals, 4 provincial hospitals, 36 district hospitals, and 499 health facilities, and then 476 health posts. This is just to show you how Rwanda has invested a lot in terms of strengthening health system, because the population can only walk few kilometers to access a health facility. Come back on Rwanda COVID-19 preparedness. In fact, Rwanda started the preparedness early before having any case even in Africa. Remember that on 16th January 2020, we have already started screening at all points of entry. That's including airports and land cross borders. So we had already the system there capturing both the details of all the individual traveling, but also screening the temperature and the symptom. So, and this information were very useful because later on, when we started contact tracing, those information were very useful to trace people who became the first cases that we had here in Rwanda. In addition to that, on 21st January, the government has already issued a public notice about COVID, which was clearly specifying the social distancing, and also hand washing, and so all other measures of preventing from COVID. And then on February 10th, 2020, the government of Rwanda started working on the capacity building, on the capacity of lab in order to be able to test the COVID. As you know, during that period, it was not easy to many countries to be able to test COVID at the time. There was no kits, there was no even knowledge on doing that. But Rwanda was proactive on doing that. So on 10th Feb 2020, Rwanda was able to test for COVID. People were already trained and we had some kits already in the country. And then on 12th Feb 2020, the government created a scientific advisory group. The government believed in science, and that's why during that period, it was very important to have an advisory group, a scientific advisory group that will help to understand and controlling the COVID and advise also the government for decision making. On 6 March, the government of Rwanda created a joint task force. This joint task force, it's an organization, a structure that was put in place to deal with COVID specifically. And that task force had a lot of experts from different fields that were supposed to contribute on containment and controlling COVID here in Rwanda. So it's a multiple expert organ where all of us we meet and work on preventing as well as contain COVID. On 14th March, we had our first case of COVID tested. And then since then, we started immediately robust contact tracing, but also establishing the quarantine protocol, as well as establishing a robust data management tools that can help us in early detection, as well as also tracing both case and contact. On 22nd March, we had already our first lockdown. So this was just to show you how Rwanda was quickly responding before even having, I remember we had our lockdown when we have only 18 cases in the country. So we're very proactive in terms of controlling the spread of virus in the country. So this is how the national coordination structure looked like. This is a joint task force. Actually, this joint task force, normally it reports at high level. There is a steering committee which is composed by, is led by Prime Minister, but the member of that steering committee are ministers from different ministries that are also contributing. For instance, we find Minister of Local Government, Minister of Finance, and other ministries that are also contributing, Minister of Defense, and so on. And then under that steering committee, there is a joint task force, which is led by a senior officer appointed by government, by cabinet to lead this one, which has also a command post and the expert advisory team. So Expert advisory team is composed not only by the government officials, but non-government officials, but also all persons who can contribute. Some they are living in Rwanda, some they are not living in Rwanda. So everyone, and they have a meeting every Friday since the pandemic started here in Rwanda, and discussing on the new methods and new science that are available that can help also to guide the intervention here in Rwanda. So mainly we find that those are partners that are working here in Rwanda or that are collaborating with Rwanda, but also the university professors, researchers, they are also meeting in that expert advisory team. And then when you look on Joint Task Force, it has 4 main pillars. One of them is epidemiological operations cell, which has surveillance, and under surveillance, there is a point entry screening. It's in charge of screening at the point of entry, health facilities, community surveillance, contact tracing, and data management. Then there is a case management. In case you have someone positive, then how do you do? There is a rapid response team that's in charge of evacuating, but there is also infection prevention control and isolation treatment. And then there is also a laboratory under epidemiological and operations cell. The second pillar is administration and logistic cell. This is also very important because during this pandemic, you need transport, you need equipment, you need some infrastructure and other finance related. So if you bring together all those people in one place, working together, it's enable fasting the implementation of any decision that is made. And there is also communication, especially for the COVID. You need to make your community aware of COVID, because that is very important. That is how these communication cells came in. That is providing information in the community to avoid misreading in terms of information that are not correct. So, and this is the one dealing with media management and the rumors management and so on. So the first pillar is plans and plan is cell. That's a planning. Normally, the planning, they always see the situation and they try to analyze and try to have plan B, plan C in case there's something wrong. So what I can tell you is that all those people, they're working in one place. Whatever they took as a decision, they meet 2 times a day, the head of those cells in the meeting for briefing, and they take a decision, and the decision taken is implemented immediately. So this was really very important in terms of quick reaction on the situation. So then come back on the data. I just put a circle on data management to show you that data was not forgotten, but the praise that was given maybe was not appropriate. So this is now when it comes in terms of practice, how data science and IT solution look like. Those are activities, those are the main components that are under Joint Task Force. One, there is investigation team. In case someone is tested positive, so the investigation team will go and meet that person and ask the people that he met before so that they can take them as suspect and follow them to just cut off the transmission. And then there is a contact tracing. So once the investigation, they have data, while they're still on the field, they have to share immediately information to the contact tracing team so that they can go to those people to ask them for isolation or for testing them to avoid transmission. Because here, every second count, the more you are draining, the more transmission is occurring. So therefore, these things has to be done simultaneously. The investigation team, while they're investigating, they needed a tool that will share information that they are investigating to the contact tracing team so that they can start immediately working. And then under this one, once someone is investigated, the contact tracing has done their job, then you need to test all those people so that you know if they are infected or not. Those information for the testing need also to be shared with contact tracing and investigation team so that they can know the next step. And if someone says a positive, they have to go to the treatment center or home-based care, depending on the protocol that we are using. And then there was a rapid response team that's in charge of evacuating. If someone tested positive, then they will come immediately to evacuate you if necessary. There are watchers who always get information from different sources, and they need to feed all those teams. And then communication also to deal with the community and providing the information, the reliable information to the community. And there were also isolation centers. Maybe I'll talk it later. Here in Rwanda, the way we were managing COVID, it was a little bit different because we started by having a supervised isolation center and treatment and the treatment centers. And then there's also decision makers who need to get all those information so that they can guide the next step. So if you look on this one, we found that we needed something in the middle that can facilitate to provide information on the real time so that everyone can do his job properly. And that's how data science and the IT solution came in the middle. So because as you know, Rwanda is a data-driven country, so every decision is basing on the data. Then the data is at high demand during this period because everyone needs to get the accurate information so that they can react according to the data that you have. And then the government realized that the data was a key pillar also. Then the structure was changed. And that is also showing the flexibility of government in terms of adopting on the situation. So the data science became a pillar among others as laboratory and so on due to the critical role that was playing with subcomponent of data management and the IT solutions. So apart that putting institution in place, we needed to do some system transformation because before COVID, our laboratory were not prepared in that way. This is how the sample flow of COVID at the beginning was. The first, we didn't have a digital system from correcting sample size. Each sample used to come with a paper, and the paper would come to the reception of National Reference Laboratory. They will register the sample in a book log. Then they will do verification. And then after that, you have to send that form and the sample to the processing room where they will put barcode to identify, to have a unique identifier. And then after that, the data will be entered in a laboratory information system, which was available in the lab. And then the sample will be sent to the testing section. After testing, then there was two things. One is that they have to register the response into a laboratory information system. And then the results will be pushed to the patient. So it was purely a paper-based system. And as you know, with COVID and transmission, the paper could also transmit virus. And you can imagine the only national laboratory that we have at the time that was offering testing. So having it infected, it was really a big problem. Then we had to think about a new approach. How can we make this paperless completely? All the intervention of COVID here in Rwanda currently are paperless, but at the beginning, we had to struggle to make this paperless. We come up with this idea. It was a simple idea, and we had to come with this decision within just 1 week, and decision and implementing within 1 week. We decided to use a tablet. We developed a system that captures information, so you don't need to to get a form with a sample. You can just capture all the information within a tablet, and then the information, at the same time, those information will be synchronized to our server in National Reference Lab. They can see those information while you are still on the field. So the time the sample will come, it will just go immediately to the testing section. And then the testing section will just do their work. And after that, the results will be sent also, will be entered in the system automatically. And then the result will be sent to the patient either by SMS, and if you want, you can also print your certificate online. So that's how we had to do the initial work of digitalizing laboratory system to avoid any paper-based system. But we also wanted to protect the national reference lab that we had at the time as the only serving for COVID testing. Secondly, we had to think about our health workers. As you know, Rwanda, as many other African countries, we don't have enough health workers in our health system. Therefore, we didn't want those health workers to be infected. And then we had to think about using robots in some of work, because we made an assessment at the beginning. We find that a nurse or a doctor will visit a room of a patient 6 times a day. And when we assess it in those 6 times, we find that most of the time they go to visit a patient, not only visiting, but supplying. Like if a patient needs something, you remember that the patient is in a red zone, no one can go there. So someone has to go if you want some water, or if you want something, food, or if you want to ask whether he needs something. So the nurses would go there in the room almost in average 6 times a day. And though there are people where they are protected with those protections, but still there was some probability of being infected. And therefore we decided to bring in robots so that they can do some of those work instead of sending a nurse every time to the room of a patient. So, but the robots also are not working in the treatment center, but also at the airport, because a robot can do a cluster screening of temperature, or people who are wearing masks, about 250 people within just 1 second. So therefore, if you have a robot at the airport, it can enforce the measurements of the prevention measures in airport. So that's how we come up with this idea of bringing the robots, and it is working. It's contributed a lot, because we could see that we managed to reduce the visit of a nurse to the room of a patient. And then another important thing was because the treatment center, they needed to see their data, they need to analyze those information, but also there is a joint task force that's needed also to see those data. We had also to make sure that the treatment centers, they are fully digitalized, and all the information that are entered in the system are immediately synchronized at Rwanda Biomedical Center servers, and therefore we could easily get some data that will help our decision makers to take a decision. But also some of the treatment, they had to get results of their patient, whether for the control, and we had to come up with a system that they can get those information within a system. So they don't need someone to take sample and go there, but you can just get a result where you are easily. In addition to that, we set the laboratory, we are ready to do that. But now the problem is, do we have enough capacity to test? That was a critical question. You remember that at the beginning, it was very difficult to get kits. And the Rwanda strategy was to test everyone. We had to test many people. And I remember that now Rwanda, we have been testing in average above 6,000 people per day. So that is in average, because at some extent we tested 10,000, 5,000, and so on. But now, if you go to the traditional way of testing, it wouldn't work because the PCR test is very expensive. And we wanted to come up with how can we increase tests using PCR, but also at low cost. So that was a question that we needed to find an answer. So we had a discussion among the scientists. We discussed on several approaches, and we come up with this pooled testing strategy to identify SARS-CoV at low prevalence areas. And you see here that this was published in Nature, and we managed it properly to come up with a strategy that will help us to test many people at low cost. So we introduced regular testing to individuals, particularly those who were like recorded as high risk, but we were able to test mass people easily. So, and then how does it work? First of all, the pooled strategy work in low prevalence areas, because if the prevalence is very high, you find it not being very useful. But this is just to show you the new cases. You can see that from March to July, in March, for instance, we had only 75 cases. So those are very low cases compared to other countries. In April, we had 169 and so on. We had a peak in August. But during all this period, from March to July, we were still in low prevalence, and we could easily use the pooled strategy. So we were eligible to go with that strategy. And if you look also in average, the new cases per day, March to July was only 17 cases per day. So the pooled strategy, this was an idea that we got from a paper of Dorfman back in 1943. We were supposed to have test n person, and we expect that n of them are infected. So what we did, there are 3 stages, which are very simple. You take a swab sample from each of the individual, then you generate n group, n subsamples, like a cluster, small groups of n, and then you pull those sample for a subset. Maybe theoretically, it can be easily seen in this way. We observed that when you do derivation until 100-fold, still you can get your sample accurately. The result can be still accurate, but we have never. If you go above 100, then that will be a problem. So we had those facts and evidence. Then we started immediately implementing the system. This is how it works. First, you have a massive testing. Maybe among all those people, there will be 1 or 2 people who are positive, but we don't know yet because we need to test them. And then you take 20 samples per pool. And you can see you have those different groups. Then if you find that in one group there is a positive, one positive, you need to redo all the entire group. So this was a little bit better because instead of testing each and everyone by individual, which is somehow costly, you can just have a small subgroup of people that you can repeat instead of having all the people individual by individual. You need a lot of kits and so on. So this is how it worked. And it's provided a lot of advantage to our country. And then this also boosted the laboratory testing capacity in the country. This is the machine that we have in the laboratory by location, Abbott machine. We have other 3 machines also in Kigali. And then Lotagen, Cobas, and GenExpert. What I want to tell you here, the most important is that those machines, not all of them we bought for COVID, but we had some of machine doing other things like HIV. We're using them in HIV testing and so on. So we just transformed so they can also test COVID. And this was a very quick decision, and it's worked to help boosting the capacity of testing across the country instead of relying on one reference lab. Another thing that we focused much was on the contact tracing strategy. When we started, we had this chart. For the R detection, we had to test someone from any point of entry because the first 400 cases that we had here in Rwanda were more linked with travelers. So then we need to detect at the point of entry. As I said, Rwanda started very early the screening at the airport. So we had in our database all people who traveled during that period. And we started from that database to reach out to them, test them, and see if they are not infected. And definitely we found that some of them were already positive. But because we had the information, it was very easy to evacuate them and also test their members, the people that they have met, family members, or the people they met home, the co-workers and so on. So all of them, we tested them. So if you find that someone is a suspect, there were 2 things. First of all, you need to be in isolation. And then they will put you in a government supervised quarantine. That is at the beginning. By now, the protocol has changed. And if you test positive, they will send you to the treatment center if you confirm positive. If they find that you are not positive, you are just a contact, they will test you and they will just follow you for, at the beginning, we started with 14 days and we realized that the 14 days were, we realized that we can rechange 14 days to 7 days. We did some quick analysis and we found that we are seeing many people get infected within the quarantine. And when we look at the fact, it was showing that the more people are staying in quarantine, the high probability, because people will be coming from different angles, and maybe some will come when they are still in incubation period, and controlling people within the quarantine was also not easy. So then we find that some of people were getting infected within the quarantine. So when our data were showing us that 7 days can work better than 14 days. So the protocol changed from 14 days to 7 days. And during that period, if you develop a symptom, they can put you direct to a government supervised quarantine. If no symptom, then the follow-up will end. This is how at the beginning it was. And then there was a systematic contact tracing. Actually, this is another paper that we are going to, it's going to be publicly available maybe next week. It was accepted. I'm reading this paper. It is a second transmission pattern of COVID based on contact tracing in Rwanda. So it was accepted by BMG Global Health. So I think next week it might be accessible, but we were looking on the second transmission, the attacklet. But talking on this, what you are seeing here, our strategy was if someone is tested positive, the black dot, we we had immediately to start contact tracing, and we grouped the suspect into 3 categories: red ring, yellow, and a green. So red ring, those are people who are very close to that person, like family members, people they have shared dinner, they spend much time with, co-workers, and so on. And then the green, those are people they met they met for short, maybe in a meeting, and so on. And then the green, those are people they met maybe in a supermarket, in a bar, and so on. So you can see that the first case that we have, this is a case number 4. We got that person tested positive on 7th March 2020, and they had 7 people who were in red ring. So those are people who were close to him. And 49, they met on different occasions, and 2, they met in maybe a public area, and so on. So then when you trace on those red ring, we took them, those 7 people, we tested them, and we found 2 of them, they are positive. And we start also a second approach. We need to trace all the individuals and categorize them. You can see that the case number 3 was detected on 14th. And we see that he had 7 people in red ring. And all those people were tested, and there was no positive. And then that is a close of chain. Then when we come off case number 2, you see that he has 7 cases in red ring, and among those 7, 5 were positive. And you had to do the same exercise. That is how we were doing contact tracing, a systematic contact tracing, until you get all the positive that you can be able to get. So that is one approach which helped a lot during the period of contact tracing. And it's helped us to identify a lot of cases here in Rwanda. And then this is the same paper that we did. Not only that, we are doing routine analysis of contact and cases, identifying how can we, which people are at high risk so that we can target them. So we had to compare the index and the cases and try to identify the attack rate among them, either by sex, but also we can see the second case per index and so on. So this was routinely done, and the results were informed to people who are doing an investigation so that they can know where to focus and which group they have to look often. The similar exercise, we are looking on different high risk factors and try to pair the high risk with the case and the contact, and then see with the positivity rate and so on. Then we had also to do some sample spatial analysis to identify the area that have high relative risk of infection among the second infected people. And this is a map of Rwanda by sector. We narrowed down to the sector level, and they could see the more it's laid, the high prevalence among the secondary infected. And then, in addition to that, we use the government, the police, national police used to escort all the truck from neighboring countries. We know some of countries, they had more infections. And then the government wanted to assure that there's no transmission, though we needed also the goods transported by those truckers from those countries. As you know, Rwanda is a landlocked country, so we are relying on our neighbors countries that are accessing the sea. But we also wanted to protect our community, so the police had to escort. But later on, we find that maybe we can have another better solution which we developed an approach of tracking the truck without having a police escorting them. And we could see them when they are moving, and whenever they stop, we could also ask them why they are stopping, and so on. So this approach helped us and reduced a lot of the work that were given to the national police in this particular situation. Another approach is that when you are doing a contact tracing, it's not easy that a person will remember all the people that they met. So therefore, it was important to use some other approaches so that you can identify other people. For instance, it's not likely that you remember everyone you met in the bar and so on. And this approach helped us a lot because we found a lot of people were infected in the bar, in the hotels and so on, and we identified them through this approach. And then Rwanda is implementing home-based care. So there are some situations after analyzing where they find that they need to put a bracelet to someone so that he can not transmit, so that he can control that particular person. So those situations are also there. Not everyone, but depending on the assessment of epidemiologists, they can decide that this person it's better to have a bracelet or not. Another important point was to identify all the high-risk areas like shop, restaurants, mainly those services that were not opening during, were not closing during the lockdown. And then we had to do a regular testing and surveillance to those high-risk places. In addition to that, we're doing random testing, like driver-through testing. And this is very informative in terms of identifying if there is a community transmission, because we just testing people randomly, and we can see what is the positivity rate among, and we had a sample of 183, and every month we can do a similar exercise like 2 times or 1, depending on the situation. So those data are guiding the interventions. The similar for the community transmission, we are looking, this is the map, and we can identify where the cases are very high in the last 26 days, and then the particular decision can be made for those areas. Like currently, the southern of Rwanda is in that situation. They have some restriction, but other districts are not, and other areas are not. But because this one has more high cases and infection, then they have to get their own restriction. And then when we look in terms of the death, we remember that a London School of Hygienic, in collaboration with WHO, they estimated about 1 to 3 million cases in 10 months, but also with about 30,000 cases of death. But if you look, actually, we compare that period, we find that we had only 103 cases, deaths, and the case were only 10,316. So why such a difference? Rwanda adopted a data-driven prevention and response to minimize this risk of transmission, but also the most important thing is that Rwanda review the strategy every 2 weeks. So every 2 weeks, we expect some decision based on the available data. So this one also helped to track very fast any problem. So this is how we are tracking also deaths on weekly basis. Whenever there is an increase or change, so the decision can be made because the deaths are discussed on their basis to see what was the problem. And was it preventable or it's not preventable, and so on. We do also analysis in terms of people who die. We look below 65 and above 65 to see if there is a particular group which is more concerned. And then we had several tools that are used to enable operations. So those are different dashboards that enable live data, and some are public, others are not public, are used internal for the operations and so on. And this is how it works. Before people go into the investigation, they discuss in terms of where they have to focus and what's the problem, because we have data until a household level information. So this helps a lot to be very precise in terms of intervention. And then we had also to monitor on their basis. Here we are looking on RT on their basis, and you can see we fit those models. This is up to today. So we can see that the RT was consistently below 0, below 1, and we can see that based on this indicator, we can tell what is the next decision. So we fit these models, and we always look on with tracking to guide the decision makers. And you can see that these cases per day can be linked on the decisions that were made, like when do we have lockdown, partial lockdown, and so on. That is given by the data that we have in place. So those are different data that we look over to see, and we look on this on their basis to see the situation and take a decision based on those information. So this is Kigali City and other provinces. This is the incidence. We are tracking incidence on their basis. So briefly, I come to the end of my presentation. I would just like to give you a take-home message. Data-driven prevention and response strategies are really working. If you focus on data, the results will be amazing. So the Rwanda government has invested a lot in health system, and we do a lot of innovative intervention to prevent and containing this virus. In Rwanda, we do adaptive and innovative technology. So whenever we find that this technology can work, we are very fast in adapting it. But also robust risk communication and the community engagement were a very key in containing disease. Thank you very much.
Thank you, Mr. Semakula. This was very, very interesting, and also super impressive how quickly Rwanda came up with new tools and how quickly they were developed and implemented. I think we have a lot to learn from that. We have a few questions. The first question is on contact tracing strategies from Don Goldman. Could you give us more details on the contact tracing strategy, including the IT platform? Were you using any of these phone apps we have been hearing about during this pandemic? And with this contact tracing, could you discuss more the rapidity of what I gather are the PCR results for the contacts? Pooling, of course, delays results for individuals. So what barriers, if any, hindered the contact tracing?
Okay. Yeah, thank you very much. This is a good question. Contact tracing was a key strategy here. And one of, as I showed, we had to go for systematic contact tracing. So for instance, if someone is tested positive, the team will come to you, the investigation team. They will come either at your home and they will talk to you, or they will call you and they will have a discussion. They will ask you, where have you been? And they will ask you, who did you meet? So that they can take those people among the suspect. And then the action is that once you are detected as a suspect, immediately you will be tested. So now the question is that that person is positive. You need to send people to interrogate that person. They are at risk. They have to wear the protection mask. And then they have a tool, a data collection system that they have, so that people that are doing contact tracing, they will be ready waiting any information entered in that particular system during the interrogation to the positive case. So once they get those information, immediately they will be proactive. They will start contacting those people before even interrogation ends with the case. So that is just to cut short the time, the delay, because the time we are still investigating, asking information, already some people they are working. So that's why we needed a system that will enable us to get information on the real time, so that we can work simultaneously, not waiting others to come and give you a report so that you can react. In that situation, you will enable the transmission, because during that period, a suspect is not aware that it's positive and they can spread. So then you need to react immediately. Then in terms of the tools, for instance, if you have been in a hotel, it's unlikely that you will know all the people who were in that hotel. And most of the time, you don't know even the people who helped you, who were like serving you. You know, it's very difficult to know people who are serving. And we have seen the situation where those people who are serving were affected. So the one of the things we had to do, we had to find another approach. How can we get this information? For instance, you can use the telephone, the telephone. For instance, if you called someone in that particular area, you can come up with an algorithm of narrowing down the radiant of that call. And then you can see all the people who are in that radiant with their telephone numbers. And those people can be considered as a direct contact, because you can narrow the radiant within 2 to 3 meters. And then you can know everyone who was in that area, he might be a suspect. And then you can call that person. And we have found cases where we find those people, they are positive, they were infected. So that is how it works. So we had to get several information and a collaboration with both cases and the suspect also, so that we can have those type of information. And remember, this is a multidisciplinary group of experts in joint task force. So everyone is willing to support in his capacity, so that we can have the one goal. So the goal was just to prevent the spread of disease in the community. So that's how we were working. So yeah. So the challenge of contact tracing is when you have community transmission. So if you saw the map that I showed, we have seen that the disease here was more cluster than community transmission. So during that period of cluster epidemic, the cluster, it's very easy to do contact tracing. But when you have a community transmission, now you don't know who is positive, who is not. You don't know who meet who, and that's very difficult to do contact tracing. But also some of other solutions can. The advanced solution, like having the IT tools that can help you, maybe if someone entered these particular places and so on, that can also contribute to still doing the contact tracing. But if you go the systematic contact tracing, you have to meet individual by individual during the community transmission. That is very difficult to logistically to be done.
Thank you. That's very interesting. We have another question on the implementation of a pooled testing strategy. What were the main challenges in updating the lab workflow and sample tracking? Many opponents to pooling question whether, many opponents to the pooling strategy question whether the extra logistical burden is worth the cost, but it is still surprising that so few locations use pooling routinely. What factors do you think enabled Rwanda to implement such an efficient and sophisticated pooling algorithm?
Yeah, I think the most the factor that's enabled this is that we had a question that we wanted to answer. We wanted to test many people, and we didn't have enough resources to do that. So that was the first motivation. The PCR are costly, and we need to test everyone so that we ensure that our people are safe. There's no way you can control a disease if you don't know the status. You don't know who is infected, who is not infected. It was difficult to do that. There's no way you can control. So if you want to control a disease, you need to know who has a disease and who doesn't have a disease so that you can get where to start. So we had that question and we didn't know how to deal with that. So we are pushed to look which approach can work for us. So then we found that we had to do pooling, as at least it was better than the cost that we would use to get PCR test kits and so on. And as you know, even if at the beginning, it was even difficult to get kits, even if you have money. So the few kits that were available, because every country wanted to keep the kits for COVID its own. And you know, Rwanda does not produce those kits, testing kits and so on. So we had to import from other countries. But also those countries, they needed them because they wanted also to test their people. So then we are pushed to go in that way. But another important element is that the management trusts the science and the fact. Because at the beginning, we had to do some experiment at a small scale. We get evidence and we prove that this can work. And the policymakers accepted easily because they trust the scientists, they trust us, they trust the evidence that we are showing. And that was also another. But this doesn't mean that there was no push, because some of people were not sure that this will work. The same when we were changing the laboratory flow, it was not easy. Actually, we found that the technology was very easy to do, to be implemented, but resistance of people to change, people understanding this is a new system and this is going to help us, it was more difficult than developing a system. So that is always there, but whenever there is a will and the support of government, so things can be implemented very fast. Thank you.
That is very, very impressive. Unfortunately, because of time, we'll have to stop the Q&A question here, but we had more questions coming in. So please, if you have any questions, you can reach us per email or our guests directly. On behalf of the Center for Communicable Disease Dynamics and the Harvard T.H. Chan School of Public Health, I'd like to thank you again, Mr. Semakulla, for joining us today. I'd also like to thank you all for tuning in to this the seminar series. Please check out the CCDD website to stay up to date on upcoming seminars and other events. And this meeting will also be on the website recording. So thank you again.
Thank you.